My name's Jennifer Wilson. I'm a general practice nurse in East Kilbride, and I'm also a Scottish Quality and Safety Fellow. I have a remit in Scottish Government as well for general practice nursing and a professional nurse advisor. I'm joined by Mary Dunnings today, who's a practice manager from Lorne Medical Centre, and Mary's going to describe one of her small tests to change later on in the presentation. The purpose today is not death by PowerPoint, it is to try and generate some discussion. So we'll have a few PowerPoint slides at the beginning, and as I say, Mary will then go on to discuss what she's done within her own practice. But I think ideally today is about you discussing between yourself what you've tried within your own practices, what's worked, what you think you perceive in the way of data to support your practices. So I've posed some questions at the end that will hopefully allow us to generate a few of these conversations. Part of my role prior to my role at the moment was supporting the access domain of the Quality and Outcomes Framework. So the first year of that was collecting baseline data and practices, and the second one was around the tests of change. So some practices having the opportunity to carry out measurement for improvement to see if their change had been successful. I've done a lot of work recently around what actually access is, and there is various definitions. The best one I've probably found is quite simply right time, right place, right person, which you're quite familiar with. However, a lot of the quality frameworks that we start to look at mention access, and good access being a real marker of quality. So I particularly like the Health Foundation's quote that good access should focus on easy access to care, including convenient appointments with a familiar clinician. So that continuity starts to come through. So this is my practice in East Kilbride. I think this is actually, I don't think it's an actual photo, I think it's the builders that have drawn this up. We are now fully functioning. We are on the third floor, but there's 6 practices within that cluster, within that practice, and we formed a cluster. One of our outcomes is to look at access and look at the patients that could have been seen by another health professional. And we're starting to do a little bit of work now and recording that on our vision system, so we have an understanding of our current state. This is where most of our access problems unfortunately unfold, and at certain times of the year that can be really stressful for our reception staff. They then go from there and end up very familiar outside the practice manager's door. So my story is probably no different from anybody else's. So just again to refresh you about option C. So last year practices were given the option as part of QoF to carry out 2 cycles of change using the access and improvement tools and demonstrate measurement for improvement. But of course not always we're going to end up with improvement. What I would urge you to do if you're not already joined the Knowledge Hub, all those storyboards that were completed last year are on the Knowledge Hub, so you'll get an idea of what practices tried, what worked with them and what didn't, what barriers they came against, so that we can start to share that learning. The Knowledge Hub site is going to be the main vehicle that we share a lot of this information. So what we did is we produced a document. I apologise, this is a really busy slide, but we produced a document at the middle of last year which analysed all the practice action reports. So that was all the current state within practices, but also started to look about where those main improvement activities carried out. So there was key access issues, and I'm sure none of this will be unfamiliar to you. So around environment, lack of consulting rooms, unplanned demand, prescription chain issues. Under equipment, phone lines not being busy in the morning, that came up on everybody's access sheet. The patient's use of self-management was very variable between practices. Growth lists were increasing, there was a lack of GPs, a lot around mismatched patient expectations, and Mary will talk a bit about that later on. And again about methods, and particularly in the increased workload that was starting to come from secondary care around certain bloods and things. I'm sure I don't need to go into that in any more detail, you'll be very well aware. So there was a huge range of improvement that happened on different scales. From within our own practice, we started to do a bit of work around signposting and extra appointments within the practice, to actually practices themselves completely redesigning their system and going nurse triage or doctor triage. There was a lot of work around skill mix, a lot of work around phlebotomy, healthcare assistants, nurse practitioners, and you'll hear more and more people talking now about advanced nurse practitioners, and my plea would be to be very sure of what you mean by an advanced nurse practitioner. This is like my broken record moment, but is it a senior nurse that you're wanting to see or is wanting to do some triage and has an extensive knowledge of chronic disease, or is it an advanced nurse practitioner who's going to take about 2 or 3 years to get to master's level to work within your practice? So be very clear when we're using definitions. So I'll hand you over to Mary. I'll give the microphone to Mary if I can get it out. There we go. And she'll just describe her change process within the practice.
I'm quite technically challenged, so excuse me. I'm Mary Dunnings and I'm the practice manager in the Lawn Medical Centre in Oban. I started in 1990. We were quite a small practice, well, four full-time male GPs and 7,000 patients, working out of a sort of very, it was something like the TARDIS that had a beautiful view out onto the bay in Oban, but it went into the depth of the world. And about 4 years later, we moved to a new purpose-built surgery in the middle of the town without a view. And we've expanded and merged practices. So now we're from having 4 GP practices in the town, we now have 1 GP practice with 10, 12 GPs working out of it. Big team of practice nurses and all the rest of the stuff that goes with it. And we now don't have any space in our building, but that's the that's the way of the world. We always have had this debate since I think even since I started in 1990 about accessibility and continuity, and how can we balance accessibility and continuity, and how do we keep these in sync, and how do, by increasing accessibility, do we lose continuity? So over the years we've had various appointment systems. We've got an extended team of practice nurses, we've got telephone appointments, we've tried most things. We haven't done triage. I think that's the one thing that we haven't done a lot of. But I sometimes spend quite a lot of time in reception, and I got to thinking when I answer the phone, you know, I know these people. There's 11,000 people on our list, and there's probably very few times that you pick up the phone that you think that you don't know something about that person. And I thought, is there trends that we can look at to see what we're doing and to whom are we doing it to? So I eventually came up with, I did it in 2012 and then I did it again in 2015, and both graphs were pretty similar, and it looks like 20% of our patients use 60% of our appointments. And that's probably why when you pick up the phone, you know nearly everybody, because in our case that's probably 2,000 of our patients are regular users of the practice. So that it got us thinking about how do we manage them? Why are these people coming to the practice? So we brought out who the patients were, who they saw, what type of appointment they were coming to. Pivot tables was something that I discovered that helped me use lots of information. And we looked at the top 100, but the top 50 we sort of concentrated on and looked at what sort of really what demographic they were, who they were seeing, and why were they coming. And it wasn't the people that we had expected. You think your high demand patients will be your frail elderly, and it's not. And when I was asked to come along, when Jenny suggested, I happened to be looking on the BBC website, and under one of their health articles, there was a practice was one of these statements, practice has cracked access, so I thought, right, better look at this. And it was a practice in Plymouth or Portsmouth, somewhere in the south, with 30,000 patients who had done this sort of work, and they had looked, and the average, their sort of high user patient was a 36-year-old woman with multiple referrals and multiple medication and multiple social problems. And that kind of matches with what we found. We have we found it was people with a terminal or a very significant illness that were needing a lot of input, people with mental health problems, people with drug-seeking behaviour, and we've got quite a high Polish population in Oban because they come to work on the fish farm processing, fish processing. And I think they have a cultural expectation that they've come with, that their first port of call is their medical service. So we've found that adjustment difficult because it's not something that we've been used to in the past. And then there was a group of people with no significant medical history. They just came. So what we did was we looked at them. The people with terminal illness and significant illness tended to have a regular GP, and we looked at who was seeing people the majority of the time, and sort of put a note on the appointment system. You get wee yellow post-its that come up and saying, if possible, fit in with Dr. A or Dr. B. We work a pool system for our sort of unscheduled demand, or the demand that happens that we feel is better dealt with on the day than postponing. And if these people turned up to what we call the pool, they would get allocated, if possible, to the GPs that were their kind of named GP. And so what we did after that was we thought, we've done this change in allocating, how do we measure that's made any difference? And we looked at the higher users. Now, some of them died because that was why they were using the system. We had a big improvement in our mental health team in the town. The Argyll and Bute Hospital wasn't quite. It was sort of not. It was shrunk, and a lot of the resource was put out into various areas. And our mental health team in Oban was pretty stretched, and we got some more resource into that, and that's made a huge difference to some of our patients. The other one was a lady who I kind of looked this week to see what appointments they had in 2016, and the lady that had 88 appointments in 2015 had 18 appointments in 2016. The lady that had 56 appointments with no significant illness has come down to 19. She gets a regular monthly appointment, so we've managed the regular monthly appointment, but she still has had the odd in between one. So the challenge is to try and get her down to a regular monthly appointment. And one of the dangers with these people that keep coming back like that, everybody just think at some point she's going to have a significant illness of some sort. And how do we, people have got so used to her coming back and forwards that it's making these, when it is something that's a real illness. So we just thought that it has been a success, but the problem is there is another wave of people coming along that are coming into the high dependency mode, and it's how do we identify these before they become using 88 appointments? You know, what sort of flags should we be looking for to move them on so that we manage the problem before it becomes a problem? And that is the man that helped me make some sense out of all this information. And I do think Vision are looking at ways of perhaps giving us better reports out of it, but I think I'll probably be retired before it comes comes to fruition.
David, do you get any questions for Mary before we break in for some discussions within our tables?
If I look up Tailor-Made Information Technology Solutions Limited, will I get to this person?
Yes, it's tailor-made it, and it's based in. There's some other sites that are tailor-made it, but it's it does tell in the sort of narrative below that it's Vision and INPS.
Contact them through the site gets back within the next 24 hours as well.
Because we use SmartFlu to record our flu. We pay £100-something, and it's good for recording our flu stuff. But he's linked in with Vision. It's INPS sort of attached software.
The reduction of the high demand appointments from 80 to 16 or 90, or from 50 to. So, what were your strategies? Did you offer longer appointments initially to kind of to find out what's going on, or did you just say, okay, we have a meeting like with the manager and we see that there's an issue, and we feel maybe it would be better once a month appointment? How did it work in practice?
I think it was very individual. We just had kind of collected the information, and then we were wondering how to make a change. So we sat down, and the GPs that kind of felt that they looked after these patients most said, I'll take that one, and I'll take that one, and I'll take that one. And it was that there was an established relationship. And then somebody else would say, well, I kind of know them as well, and I'll do that. The very high users, there was probably a discussion in a consultation, right, I want to see you back in 2 weeks' time, and then perhaps I want to see you back in 3 weeks' time. It was more giving, almost before they left the surgery, they were given another appointment that they knew that they could come back to, rather than it was left with them. And that worked very well for a few of them. I think the people with what I would almost say drug-seeking behaviour, that were doctor shopping, were more difficult to manage, because they weren't so attached to one clinician, and they perhaps weren't looking for consistency. So that was more difficult.
Less of a question, more of an observation, but I listened to a number of presentations about, kind of managing the frequent flyers. And, I think there is a certain danger in that. I mean, it's fine, as you've discovered from your own investigation, that there are quite a number of patients who probably quite appropriately are being seen frequently, particularly the terminally ill, and some, a number of patients with, significant comorbidity, chronic disease, who do require regular intervention, monitoring, reassurance, or whatever. And that, these figures of 20% of patients use up 60% of appointments, that's no surprise, because although people seem surprised by that, I mean, but no, you know, in any population, not everybody is unwell at the same time. We couldn't cope if they possibly were. We hear the same thing about hospitals. 10% of the population, or you know, 80% of their resources are used by 10% of people, kind of thing. I think we've got to be a bit careful about this. It's fine if you've got an intervention that works to appropriately reduce the attendance of these people. But a lot of the interventions that I've seen, certainly with anticipatory care planning, haven't made an awful lot of difference. You know, the person still pitches up at A&E, or they still pitch up at the general practice because of the nature of their behaviour, or they are genuinely unwell. I suppose what I'm saying is there is a limitation to this methodology.
Well, I don't. It was just a kind of almost an interest. Is your gut feeling? Can it be supported by anything?
So I'd be quite interested about where you shifted. So because it's not just about the frequent flyers, it's about who's seeing those frequent flyers.
Mm-hmm.
So I think the methodology is still strong because you need to look at where your demand's coming from, and then the alternatives, how you manage that. So I'm quite interested about the mental health work you mentioned. So some of this work might be worth looking at how you demonstrate the shift away from the GP, not just about the number of appointments, but the other work that you've done to pick up the activity elsewhere in a more appropriate setting.
I think the other thing that the strength of the work shows the importance of continuity of care, which is, we've talked about before, getting the balance of that is really difficult, but what Marie's evidence does, having continuity does reduce the contacts with the practice. And as you say, you will have high demand patients. Sometimes I think it can be quite striking though at how much time and resource a lot of these patients are using up within our practice. But I definitely think there is something around continuity of care. When we look at right time, right place, right person, if we're then looking at the quality side of that, then that's when we bring in the continuity.
I also had a question around whether you started thinking about with the integration agenda, whether this has helped you link out to social work to look at some of the, you know, with some of these individuals, there will be elements of isolation, loneliness that will play into this.
One of it's not a scientific or anything. It's just one of the observations I would make about perhaps general practice is now general practice is the friendly face. Social work, Department of Work and Pensions, job centres, all are these sort of IT call centre driven organisations, and they can pick up the phone to the general practice and speak to somebody that will perhaps say to them, "Oh, it's a nice day out there. Oh, and how are you today? And how can we help you?" And I don't know whether that is something that perhaps some of the other organisations have lost, and general practice still has that family pick up the phone. And we had one lady who phoned nearly every day for a prescription either for herself or her husband, and I said, "No, we can get this. The pharmacy will deliver it to you once a month." And she didn't want that because her husband had dementia. She phoned to us to speak to somebody. She then took her husband on a walk to the chemist to pick up his medication, and it was a purpose. It was something, I have to go out, I'm going to the pharmacy, I've spoken to the receptionist, I've spoken to the pharmacist or the girl in the chemist shop, and my husband and I can walk home. And it's about that personal well-being rather than, it's about...
Any other questions?
Just within a health and social care partnership context, very often the people who are identified as being frequent attenders of practice are also the folk who are identified as being frequent users with all the other services, and therefore there is a joint agenda. I get to see a lot of the suicide reviews, which is everybody who has completed with suicide whilst knowing to mental health services. You never come away from it thinking that there have been people trying to avoid work. There's huge numbers of people putting in effort, and still you end up with an unsatisfactory outcome. And it's the discoordinate effort. So in terms of, do we as a cluster have a common agenda down this, absolutely have a common agenda, and therefore there is some benefit in saying, and I first saw it in terms of somebody in the States who presented, I think it was house fires and the fire department. Selling news joints, no, sorry, the fire department presented house fire, and the policeman at the same point said, that's odd, that's a mark of domestic violence. You know, so there are shared, and we're now in a position where if we can just get the right conversations, actually we can get somewhere.
Yeah, again, I think it was probably more an observations than motivations. I mean, I've done a very similar piece of work to you talking about here in terms of both looking at kind of frequent flyers and the cumulative effect of that. And that cumulative volume curve, you're never going to address that cumulative volume curve by addressing the people who have 70 attendances in 1 year. Because there's not very many of them, and even if you take that 70 away, you've still got 45,000 left there. But to a certain extent, I don't think that that's probably the motivation behind doing a piece of work. Somebody who's turfing up a general practice, 70, 80 times a year is, as Chris says, probably also turning up at A&E a dozen or 24 times a year and social work and so on. So there is an issue of unmet need there.
Yep,
And just purely in terms of there's clearly something that's not a quote-unquote normal way to behave. It's at the very margins of what we would expect in terms of a distribution curve. Can we not do something here to try and help this person to meet their needs?
I think that was more the motivation than, because even if you save 30 appointments with one person, it's not, in the scheme of 45,000 appointments, it's not that much, but it might make that person's life and experience better.
It's tying it in with anticipated care planning, all the other things that we're doing within practice. I think that's you're free to go now. I got a wee nod there. Is there any other burning questions anyone's got? Or you just want a wee now? Thanks very much for your time. Thank you. Thank you.